since I was going to ask questions for Mary, Paul, and Jeff, so we'll start with Mary and Paul, since Jeff had to go move his car. Makes sense.
We're going to talk about Jeff.
Good, we're talking about Jeff. Actually, I'll start with you, Paul, since you're volunteering. So this is, I'm going to actually play a role of this mic on, because I'm going to hand this to people who don't have mics, which will be you, Paul. Sorry. I'm going to put my mic on. All right, you should be able to hear me. Can you hear me? Yes? Good, cool. So, Paul, one thing that we hear a lot from the health insurance in general and leaders like George Halverson. First of all, for those of you who don't look, Paul Macielak is the president and CEO of the New York Health Plan Association. And I think what's interesting about his resume in terms of the kind of way that New York approaches healthcare is he comes out of hospitals, he comes out of state government, he doesn't come out of the for-profit health insurance industry. It reflects the way the industry here is different than a lot of places in the country. And one thing that the industry has pointed out, generally in leaders like Kaiser's George Halverson, is that the main driver of health insurance costs is not insurance company profits or administration, it's really the cost of services. And we've heard today that policymakers in Vermont and Connecticut are looking to public insurance to remake the health delivery system and control provider costs and make a system that provides better value in ways that the private health insurance system so far hasn't been able to do. So is it reasonable for New York policymakers to be looking to a public insurance entity to deliver greater value in healthcare in New York?
Well, I think that goes to I'd say a broader question of what are the ways they intend to do it. And the state can dictate provider payments, they can dictate the benefit package, but I think plans really are more sensitive to the needed balance or the tension between those that are paying and those that are getting the benefit. And so when they deal with the small, in particular, small group market, they have to balance what does that small group really need and what are they willing to pay. So they need to better tail what the benefits are and what the value proposition is back to provide for their members. And that's been the thorny issue that all health plans and certainly now government, certainly in New York, are now starting to confront. I mean, this past year's budget, I mean, the whole Medicaid reform redesign effort, the MIT effort, clearly highlighted government's desire as a purchaser to try and get a better value proposition, and they in fact look to health plans, health plan management, care models to help drive better value for the state down. And so I think the private sector in terms of health plans vital to a overall solution, and I think we'll always have a role in terms of trying to design a package here in New York City.
Thank you. I'm going to go with Jeff next, since he got back. Time is so fast. Jeff Gold, you've got a resume, but the one thing I want to say is I've worked with Jeff a lot when he was the head of the Healthcare Bureau for two different New York State Attorney Generals, and did some work with Citizen Action on enforcing the Managed Care Bill of Rights, which was a lot of fun. So it was great working with him. Jeff, the question I have for you is, I was invited several years ago to speak at a panel at a Haney's annual meeting. New York Presbyterian President and CEO Herb Pardes was on that panel. And I was really interested. He started his presentation by saying that a survey of hospital CEOs in New York said that half of them would support a single-payer plan, which I thought was interesting. He said the motivator was the huge cost and hassle of dealing with multiple insurance companies and plans. So I guess my question for you, do you think there's a place for alternatives to private insurance as we implement the ACA in New York?
The engine's still running my car, by the way. Let me make a 10-second detour. Notwithstanding Assemblyman Gottfried's mention of otherwise state dysfunction, the honest suck-up tip of the hat is that the reason that New York has had the kind of legislation it's had over the past couple of decades is because of the two chairs who've been here through all of that. And the objective intellectual, honest dialogue you get to have, win or lose on an issue. So it's been hugely important, and that's why we made the progress we made. So thanks to both of them. I think the hospitals are mostly confused right now about what to react to. I think emotionally, a number of them believe that single payer is an answer. I mean, I think, you know, if you cut me and made me bleed, going back to my consumer protection days, you know, a lot of my heart is in that kind of approach. But I think the other pragmatic problem, and we saw that in kind of the premium rate approval process, is that the hospitals feel terribly tied to their relationships with the managed care industry. They rely on that relationship. They like it, they don't like it, but it is part of their collaborative future. And they are very concerned about kind of the impact and the unintended consequences of what happens to a market that is wired the way it's hardwired. I mean, we talked about the polarization that is kind of historic. We really have almost two markets in New York. You know, south of the Rockland County border, you mostly have profit payers in the game. North of that border, you have kind of cities with homegrown regional not-for-profits. A very different experience and a very different discussion that kind of takes place in terms of kind of healthcare regional planning that goes on what is possible and what is not possible. So, you know, I think we're very schizophrenic about it. I think the reason we're additionally schizophrenic about it is that we would like to leap forward into accountable care organizations. We would like to leap forward into collaborative care models. We see the benefit of all the medical home enhanced futures, but we are struggling terribly with the idea that the other influence tunnels that have to change, patient behavior, physician behavior, our behavior, payer behavior, are not really part of the holistic approach to any of this. And as a result, it gets very hard to make choices. My last detoured answer to your question is, you know, we were pretty excited about a lot of the accountable care reg that was going to come out of the feds. And 400 pages later, by and large, most providers think there's no possible way to do it. Can't do it. It does not change patient behavior in any way. And the shared savings contemplated by the federal Medicare model are impossible to achieve in the time frame that's been created. So, you know, I think we're open to whatever payer model allows us to sustain the mission that we want to do, but I think we're kind of hardwired in the market that we're in, and we have the opportunity to build tremendous collaborative relationships with the existing plan structure. But everybody has to ante up to do that.
We'll come back to that discussion in a minute. But first I want to turn to Mary Clark, our third responder from a New York stakeholder group. And I've worked with Mary since I first came to New York, since 1985, where she was my longtime colleague at Citizen Action for New York. Mary, unlike Connecticut, New York now relies on private insurance to finance care for Medicaid. So you've got Medicaid, almost all the Medicaid beneficiaries of Medicaid managed care. Our state employees, one of only 4 states in the country that uses private insurance for our state pools as opposed to self-insured. So, you know, where should New York start? If New York wanted to do a public option, where would it start, given that problem?
That is always the challenging question here in New York, because for what you say is, where do you start? Because unlike Connecticut, we do not have a large group of people who are self-insured or publicly covered like in Connecticut. And like you said, all the other states other than in New York. There's only 4 states, and we're unfortunately one of them that we actually do not self-insure our public employees. But there is, and I really believe that that's an option that we should consider, and that's something that we should look at. I know CSEA, Public Employees Union, has been looking at that as a way of cost saving, saving money. The Civil Service Commission or whatever has said, well, we can make savings by negotiating rates. But we really believe that, and CSEA also believes that they could have greater cost savings if they were self-insured. And many entities here in New York State actually do self-insure. The county I come from, Broome County, is self-insured. There's some consortiums of counties that come together and self-insure. We have the New York State Health Insurance Plan that people can negotiate into. So one suggestion would be of how do we begin to really move forward with a public option would be to take the New York State Health Insurance Plan, creating an option for self-insured, the public employees to self-insure, to create that public insurance entity with that combination. And I also agree with Brian that one thing that I was looking at as well was really looking at the basic health plan. I know in Connecticut they had done a study, Gruber from MIT or something, did a study that said if we created a basic health insurance plan in Connecticut and put it into the public option, that would save millions and millions of dollars to create the plan that way. So that combination of doing the public employees, the night shift stuff, and the basic health plan is an area that we can really begin. And I also think that we need to really look at, in New York State, and I really do also commend both of you for the great work that you've done here in New York State. We do have public programs, but they're publicly financed and privately run. And I would suggest that we open that up in terms of a managed care entity that's publicly run that can be part of this as well. Because actually in my county, I thought I saw Carl Young here, but I'm not sure. We had started a public Medicaid managed care program well before the state had. And we had a public managed care entity in our county that saved tons of dollars, so much so that we expanded coverage to dental care, all sorts of different things. So it's proven that it actually can work. And so I would suggest that combination of things that we would really look to do that. And I think doing through a public option, we also have more leverage in terms of negotiating and setting a whole bunch of quality standards. Because we really want to see setting forward this exchange legislation as really a game changer as well. We really want to see things that, that improve quality outcomes, that we do a pay for performance, which we have done already with our managed care, our Medicaid managed care and Family Health Plus, that have proved increasing quality in our public programs. And so I think that we really want to do that. We want to reform the healthcare delivery systems that people have spoke about, and also reduce healthcare disparities. And I think one thing I advocate for everyone who's here today is that we need to pass exchange legislation, and we really need to do it this year in the last 3 weeks. I know you guys can do it because we have these things last minute, and we really like to see, and I respectfully disagree, is really to see a statewide exchange where everyone, that everyone is in, that we have a combination of both the small business and individuals all together in one exchange, and those kind of things. But I think we can get there, and that's what we need to do this year. Okay.
So let's bring other panelists in, and I can see that Jill is anxious to make a
Well,
comment.
I just wanted to correct some facts. We actually were we also, until very recently, had our state employees were fully insured. They were not self-insured. That just changed within the last year or two. So it is possible to change it. There's some paper savings, which is really just a timing thing. So where you don't have to pay your premiums up front. Now if you go self-insured, so you get a little window of savings. It's one time. It's not really real savings. And our Medicaid program actually currently is contracted out to private managed care, and we're about to change that. And one of the first things the governor, which advocates have been advocating for a while to change it, and one of the first announcements the new governor made was he was going to take a Medicaid self-insured. And so they've actually put an ASO contract out there for bidding. And right now we have the only nonprofit insurer, I think, in Connecticut is a Medicaid insurer that was built out of the community health center. So I'm not, I do worry about what's going to happen to them. The other two are private and United. So we're in the process of changing that right now. And so Sustanet was always envisioned to be self-insured. Then the ironic part of it is that the public option, if it's going to have to compete in the exchange, is actually going to have to become a licensed insurer. So for our public plans, we're going self-insured, but ultimately the public option, in order to compete in the exchange, if you look at the ACA, it's got to be a licensed health insurer. So everything is flipping around.
That's encouraging for New York.
So just trying to cause a little bit of a food fight here. This question of cost and how we drive that, Jeff, you talked a lot about who's going to take the leadership. Everybody's sort of wired to do what they're doing. And again, I haven't been closely watching New York for a while, but I know that when I was here up till a couple of years ago a lot, you would often do reports from Haney's talking about how insurance company costs are too high, and they're a big driver of costs. And there was a constant refrain from Haney's. And then, but as I said before, we hear from the insurance industry a lot, and provider costs are going up. So the question I'm looking at is, how do we break through this hard work? Where's the leadership coming to give what the consumer wants? It's interesting to me that Brian says the exchange is experts plus business, labor, and consumers, the people who are paying for coverage, as opposed to people who are actually providing and making their livings off of it. So where's the leadership come from, and what's the role of the public versus the private in providing that leadership?
Well, I think the challenge that we continue to see, I think I even saw it yesterday at a roundtable that Senator Hannon threw in a couple of pieces of legislation, was that kind of the focus of the discussion was from the point of view of really just one of the stakeholders who had, one of the groups who had a concern about something that needs attention in the law, two different things having to do with non-par doc compensation and having to do with facility fees for office-based surgery, which are very viable issues to talk about. But it was almost, in my mind, as a takeaway from the discussion, secondary to talk about kind of, what did it really mean to a consumer getting a balanced bill in the hospital? What did it really mean to the affordability for a plan to be able to pay for it? What did it really mean in terms of if you licensed office-based surgery so inexpensively that it damaged CONs and all of the structural work that hospitals do in order to have the hospital there. Those are fundamental parts of the same conversation. And I think really wasn't central to the kind of the foremost point in the minds of the people worrying about the legislation. And I think that in every discussion that we've had in a lot of the managed care legislation that we've gotten done together, there has been a willingness to find common ground among stakeholders working closely with government where you have to ante something up. Behavior has to change. And, that behavior is a balancing of what plans are able to do. It's a balancing of hospitals not wanting to play defense in a world of geographic variation and hospital-acquired conditions and all of that, and taking some ownership. It's docs realizing that in certain circumstances, this is just my personal bias, but the sky's not the limit. But and how do you align those things when you're in competition in certain circumstances? So, I think the big step forward to get any of this done is the stakeholders have to put something on the table together and not leave the room until they kind of wrestle these things to the ground, and fundamental behaviors have to change. They can't just be, a piece of it. And I continue to be troubled by seeing that in the different public discussions we're having about exchanges, about ACOs, about care modeling, that it's still from the perspective only of what does my group mostly need. And I think that fundamentally has to change.
Brian, in Massachusetts, one of the things that's really happened as we've gotten everyone covered there is to focus on costs more. And I was struck by something that the Partners Healthcare Plan did in terms of voluntary offering costs. Can you talk a little bit about that, and also how voluntary, what led to that,
Sure.
and also what the changes on payment system reform that is looking at in terms of global payments and stuff in Massachusetts.
So I think that there's a lot of this kind of Bay State pride. I want to acknowledge, it's absolutely true that New York was ahead of a lot of states on a lot of these things, and doesn't get the credit. But for the state that at least thinks of itself as the first state to kind of figure out how to get everybody covered, we now want to be the first state to figure out how to bring the cost of care down by moving to new payment models and really paying, like we said, for quality, not quantity, paying for value, not volume. Those are the catchphrases. And turning that into reality is very hard. So the run-up in insurance prices predates reform, and it's not really due to health reform. It's due to the market dysfunctions in the state of Massachusetts, where you have a big concentration of teaching hospitals in the Boston area with tremendous negotiating power and a deregulated hospital system. And so as that got worse and worse, the governor wanted to do two things. One was a long-term cost payment reform issue, but a short-term empowering the Division of Insurance to be much tighter on insurance prices. And the way that played out, it played out in lawsuits, and the Partners, which is the big merger of the two biggest teaching hospitals from the mid-'90s that really sets the bar at the highest in terms of reimbursement rates, decided it's kind of a PR move and to sort of turn down the heat to say we're going to give back $40 million this year as a sort of a return for the high rates that we've been charging to the small business. In the meantime, and that's going to lead to a modest reduction in small business insurance rates for next year. But in the meantime, this payment reform push is going forward. The hearing on the governor's bill was this Monday. There's a lot of energy around it, and I think the same thing is happening in Massachusetts that happens that you mentioned, where everybody is for this with a but. So the hospitals are all for payment reform as long as, and then they got a bunch of wish lists, and the medical physician groups, the same thing. But frankly, we as consumer organizations, we have our broad coalition. We're very much in favor of payment reform, but we have our wish list that we're demanding. We want to see transparency. We want to see the consumer voice in decision making. We want to make sure that savings get returned in part to consumers. We want to make sure that the patient confidence, patient experience measures are part of the measures of quality, and so on and so on. So we have our own demands, and we're entering the political process trying to figure that out. But I want to predict that we will pass the bill, probably not this year, but next year, pushing the state, starting out with Mass Health and our Medicaid program and state employees insurance as the first to go on this, and eventually leading to a process for the entire state to be on ACOs and global payments in over a 3 or 4 year period.
So if you do that, what's the role of private insurance at that point?
Well, it brings up an interesting question, doesn't it? Because, right now employers pay the insurers and the insurers pay the doctors and hospitals. And the insurers are there for a real reason, because they manage the risk and they have reserves and so on. This new system, we're supposed to be making it simpler, we're actually making it more complicated. Employers pay the insurers pay the ACOs, and the ACOs pay the doctors and hospitals. So it brings up an interesting question. What is the role of the insurers? And one answer is, well, they're there to manage the risk because they do have reserves and they are licensed, and if something goes wrong, the insurers are there to kind of protect you. But that's really an accounting function that could be handled in another way. And so I think it's going to raise these questions in a serious way somewhere down the line if this rolls out successfully.
Paul, you want to jump into that? Who needs the mic?
I think it goes back to whether the ACO becomes a reality, and whether the ACO function in terms of risk, accountability, all the other standards that health plans today need through licensing and their oversight, but also apply to the ACOs as they get structured. And that, we've seen in New York, we call it a different label, when there have been PHOs, and then there are all sorts of other variants that have been advocated for physician, hospital, payment models that really haven't gone to the next step because they haven't been able to get to that sort of an agreement, a global approach or a sharing of the dollar, so to speak. It's only been through a health plan, hasn't been, it's been through separate contracting and network development over time that it has occurred.
So here's a real issue we're having, and I know somebody wants to talk.
Go ahead, and then we'll go back to Brian.
Sure.
Yeah, and unfortunately, I'm going to have to leave because I've got to get the train back to New York. But, I think insurance companies do several things, all of which I think can be and ought to be public functions. They design benefits. They decide whether a claim is covered by the benefit structure. They assume, although they assume risk, but also try to avoid it, and they decide how much each covered life has to come up with in cash in order to be covered. And with a public coverage system, the public would be deciding the benefits. Either a public entity or a provider entity would be deciding what services actually get paid for. But I think an important change is that instead of the CEO, multimillionaire, covered life contributing the same amount to the cost of the healthcare system as the janitor at the company, this system would be funded on public financing based much more on ability to pay. So to me, there are a whole series of very important functions that are much better served by a public entity than under our current system.
All it takes is money.
Pardon?
All it takes is money.
All it takes is money. And
Now,
we're gonna get it.
I was
So
just
we
going to
have
say,
Brian and then Jill and then
Well,
go ahead, Senator. Go
one
ahead.
sentence, now you know why we have two houses in the legislature.
I was just going to say, before we get to the existential questions, one of the practical questions that's coming up in our context is insurer reserves. And these physician groups are saying, well, maybe you should transfer some of the reserves to us since we're taking the risk. The insurers are saying, no way. That's our money, baby. And how this plays out, I don't know.
Jill, go ahead.
I just want to say, in Connecticut, there's been a lot less ACO talk, and we've really been focused on, well, the state is a large payer already for health care, and the state can choose as a payer to change the incentives and say, we're going to pay for patient-centered medical home, we're going to pay for more chronic disease management. And, right now, maybe some of those funds are going to a private insurer for a nurse on the phone, and what we're saying, in Arizona or something, but instead we're going to use those funds to pay for better primary care, better care management in our communities. We haven't gone as far into Vermont and really designed it, but Susnet is based on the fact that the state is already paying for a lot of health care, and if they can set the terms of what they want to pay, then the provider community, the incentives will be clear, and they'll be able to drive the changes that we all know need to happen. And so that's the theory of Susnet, and the public option would be a piece of that. But Medicaid is a huge piece of that, and the state employees. And I have to say, in our state, the state employee unions have really stepped up to the plate and have said we are going to. That's the kind of health insurance we want. It's really, the ACO discussion is just barely getting going. The state employee plan, for instance, is trying a pilot program to pay for patient-centered medical home, and that got a large physician group, which we hardly have any of, but we happen to have one, that has a little offices all around the state to step up and say, okay, we're going to get our NCQA accreditation. And so in a state that had hardly any patient-centered medical homes, all of a sudden everyone's getting on the bandwagon for that. So the state really is driving change as a payer.
We're going to